Is it clear now? Hello.
Yeah, yeah.
Okay. So, good evening, everyone. Then we have come to an end of our TRICS IDCCM theory course, and now it's time. After this live quiz session, we'll be having two mock exams, which will be simulating your actual real-time IDCCM theory. So people who have still not joined the course have still an opportunity to at least go through the mock exams where you will be given a real-time experience with detailed debrief videos. So you're still welcome to join the course. And people who are already in the course, it's time right now to buck up and you know these last few days of preparation, revision with our mock exams. It'll definitely help you. So I won't delay any further. I'll ask Dr. Vani to please start the debrief session.
Thank you, Alisha. So this debrief for the 10 questions that were given in the quiz we'll be seeing now. So the first question was, in severe acute pancreatitis, which of the following statements is
Vani
true?
ma'am, please share your screen.
Oh, okay, I'm sorry. I thought I already shared. So my screen is visible, right?
Yes, it's visible.
Yeah. So what is true in severe acute pancreatitis? So the first option was a presence of gas in the necrosis is pathognomonic of infected necrosis and is highly sensitive for the diagnosis. That is false, and we'll be seeing later why. Elemental feeds demonstrate superior tolerance to standard polymeric feeds is also false. It is recommended to add parenteral glutamine to TPN in patients for whom enteral nutrition is not feasible, is the true answer in this question. And parenteral calcium administration is not recommended to normalize ionized calcium in all patients. So when we look at severe acute pancreatitis, infected necrosis is one of the very severe complications which is seen in approximately 30% of the patients. And usually it is a late presentation. It usually happens after 2 weeks of the course of illness. However, it can occur little earlier. Clinically, it presents as a clinical deterioration with abdominal pain, tenderness, and signs of inflammation and sepsis. So diagnosis can be done clinically. It is suspected whenever there is a clinical deterioration and a CECT of the abdomen has to be performed. So if the CECT shows a gas formation in any of these collection, it proves that there is an infection. This is with a very high certainty, which means that the specificity of gas in the necrosis is 97% specific. However, the sensitivity is only 56%. So only about half the patients with infected necrosis will show gas formation in the CECT. So which cannot be taken as which is why the first option is wrong. So in case a CECT is inconclusive for diagnosing the infected necrosis, the next step would be doing a fine needle aspiration of the collection. Fine needle aspiration also is not 100% sensitive. It picks up the organism probably in around 78 to 80% of the cases. And also it itself is associated with some complications because an infection could be introduced by the procedure itself. So if there is a high index of suspicion, then it is always prudent to start the patient on antibiotics and treat the patient rather than waiting for the results. So regarding the feeding, traditionally it was used, fasting was usually advocated to provide a pancreatic rest and prevent the stimulation of the pancreatic enzymes till the enzyme levels return to normal, and the patient was frequently started on parenteral nutrition early itself. However, prolonged fasting has been shown to have several deleterious effects, including decreased bowel motility, bacterial overgrowth, loss of integrity of the gastrointestinal mucosal barrier. This will lead to increased permeability and translocation of the gut bacteria into the systemic circulation, which will promote pancreatic infection. So, feeding is always advocated provided the patient is able to tolerate it. So, enteral feeding is preferable to parenteral feeding in patients with severe acute pancreatitis. An on-demand oral diet is started at around 72 hours or earlier if the patient is able to tolerate. Feeding is initiated through a nasogastric tube if the oral intake is poor, and a nasojejunal tube is considered only in cases of digestive intolerance. So there is no difference in outcome whether the patient is started on a nasogastric or a nasojejunal, and since nasogastric is much easier to place with, it is always preferable to nasojejunal feed. And for using enteral feeds, only standard polymeric mixtures are preferable. The elemental or the semi-elemental mixtures do not provide any advantage for feed tolerance. So standard polymeric mixtures are used for enteral feeding. So regarding intravenous glutamine, so intravenous glutamine offers a benefit when it is added to parenteral nutrition. It can reduce the incidence of infections and also can help in reducing the mortality. So the guidelines recommend parenteral glutamine to be added to total parenteral nutrition in patients if enteral nutrition is not feasible. Finally, coming to hypocalcemia and pancreatitis. So hypocalcemia is frequently seen in acute pancreatitis. In fact, it is one of the components of the Ranson scoring system. And a presence of hypocalcemia, it can be considered as a marker of poor prognosis. So calcium itself is required for the normal secretory function of pancreatic acinar cells. And the high level of calcium in the cytosol is having an important role in the pathogenesis of pancreatitis because it is responsible for premature trypsinogen activation, vacuolization, and acinar cell death. So why is there hypocalcemia in pancreatitis? One of the proposed mechanisms is there is an autodigestion of the mesenteric fat by the pancreatic enzymes and release of free fatty acids, which on which the calcium deposits and forms the salts. So hypocalcemia correction should be done with extreme caution in patients with acute pancreatitis because calcium plays a central role in the pathogenesis of the acinar injury and cell death. And there is no evidence to support calcium correction by parenteral calcium in patients who have mild to moderate hypocalcemia. In case a patient has severe hypocalcemia, which is also diagnosed by a low ionized calcium with clinical signs like neuromuscular irritability, QTC prolongation, in such conditions, a calcium correction has to be given, but the approach has to be individualized. So all patients should not be given calcium correction in severe acute pancreatitis. So going on to the next question. A 30-year-old male with traumatic brain injury who had complicated by VAP and is now recovering from sepsis is on the ventilator and he is agitated on and off. Which of the following actions is recommended? So the answer here would be dexmedetomidine infusion to achieve a light sedation is recommended. And melatonin administration is not recommended. Midazolam is not preferable and prophylactic quetiapine should not have been started. So this patient probably is in delirium, which has to be assessed by using some kind of a scoring system like the CAM ICU scoring system, which takes into account the fluctuating course of the mental status changes, the presence of inattention, alter level consciousness, and disorganized thinking. So the clinical practice guidelines for prevention and management of pain, agitation, delirium, immobility, and sleep disruption in adult patients in ICU give certain recommendations for the prevention of delirium as well as regarding the sedation and immobilization in the ICU in order to prevent delirium and further complications. So according to these guidelines, there is no recommendation to use melatonin or dexmedetomidine to improve sleep in critically ill patients. In fact, propofol is not recommended to improve sleep because it can actually worsen the quality of the sleep. A sleep-promoting multi-component protocol is suggested, which involves non-pharmacological methods like using earplugs, eye shades, relaxing music, etc. So with regards to sedation, it is suggested to use light sedation versus deep sedation in critically ill patients. And the sedation scoring system, there is no strict guidelines as to which scoring system to use, but a RAS, Richmond Agitation Sedation scale of -2 to +1 is preferable and it can be taken as light sedation. It is suggested that either propofol or dexmedetomidine over benzodiazepines to use for sedation in critically ill patients who are mechanically ventilated. This is because benzodiazepines have a propensity to cause delirium when they're used for sedation. So they're used only in specific situations like alcohol withdrawal where they may have a benefit. Otherwise, it is preferable to use propofol or dexmedetomidine. And in order to prevent delirium, it is suggested not to use any of the atypical antipsychotics or dexmedetomidine or ketamine in order to prevent delirium. So there has to be a multi-component non-pharmacological interventions like um, reorientation therapy, cognitive stimulation, use of clocks, etc., to reduce or shorten the delirium. Improving sleep quality by minimizing light and noise, improving the wakefulness by reducing sedation, reducing immobility by early immobilization, early rehabilitation therapy, and reducing the hearing and visual impairment by using devices can help in the prevention or at least decrease the shorten the duration of the delirium in critically ill patients. So the next question is about pressure regulated volume control mode of ventilation. All are true except. So the first option is a lowest inspiratory pressure is set to achieve the set tidal volume. High respiratory drive states can cause dyssynchrony and increase work of breathing. The maximum available pressure is 5 centimeters below the preset upper pressure limit. So these are all true statements with regard to PRVC, whereas a constant inspiratory pressure being delivered irrespective of lung compliance is the false statement. So looking at detail at the PRVC mode of ventilation. This is like a dual mode of ventilation, which incorporates both the features of volume control as well as pressure control ventilation. So what this mode does, the ventilator attempts to achieve the set tidal volume at the lowest possible airway pressure. So it's a closed loop type of ventilation where, based on the respiratory mechanics of the patient, the feedback is given to the ventilator on a breath-to-breath basis. Accordingly, the machine will adjust the inspiratory pressure to be delivered in order to achieve a set tidal volume. So it has the benefits of a guaranteed tidal volume while also having a variable flow of the pressure control ventilation. So how do we set the ventilator for this? So there is a upper pressure limit which has to be set. This is like a safety limit. So if this upper pressure limit is reached, the ventilator immediately cycles to expiration as a safety measure. So below 5 centimeters below this upper limit, the alarm will be activated to indicate a limited pressure. So beyond this pressure, the pressure will not be increased. So the set tidal volume may not be delivered in this condition. So how does this mode act? So initially, the first breath which will be delivered by the ventilator will be a volume control breath in which a plateau pressure measurement will be taken by the ventilator. So for the subsequent breaths, that will be taken as the inspiratory pressure, and the tidal volume which is being generated will be monitored by the ventilator. So based on the previous breath's tidal volume, the next breath's inspiratory pressure will keep varying between the different breaths in order to maintain the set tidal volume. So looking at the graph of this PRVC mode, we can see that the pressure times scalar, the pressure is not constant. It is varying according to the breaths. So the tidal volume also varies according to the pressure which is delivered. And once a perfect tidal volume is delivered, which has been set, then that inspiratory pressure will be used for the subsequent breaths. So what is the limitation of this pressure regulated volume control mode here? The problem is that because if the patient has an increased metabolic demand, the patient requires a very high flow, the patient will try to take a higher tidal volume, the patient effort will increase. So that will be sensed by the ventilator because higher tidal volumes are being produced. The pressure support or the inspiratory pressure which is given by the ventilator will decrease. This basically means that the patient will get less pressure support when actually they may need more support. So this is a type of dyssynchrony which is possible in this type of ventilation. So it cannot be used in patients who have very high metabolic demands or who have any other features which is going to cause them to take higher tidal volumes. So going to the next question, this is a graph showing the pressure volume curves of a patient who is on ventilation for ARDS. So the pressure volume curves at different points of time have been depicted. So the curves are shown for the baseline value at 12 hours and at 24 hours. So which of the statements is true? There is an increase in compliance after 24 hours and it depicts a volume control ventilation. So this pressure volume curve, as we can see, there is a constant tidal volume for which there is a change in pressure. So basically this is a volume control ventilation, and compared to the baseline at 24 hours for the same type of for the same volume, a lower pressure is being generated. That means that at a lower pressure the tidal volume is actually good, which means that the compared to the baseline the compliance of the lung has improved. So the answer would be A, which means there is increase in lung compliance and it is a volume control mode of ventilation. In pressure control mode, here the pressure will be constant. So the shape of the PV curve will be different. So next question is on CRRT. A 70 kg male patient is undergoing CRRT in the ICU and the settings are as follows. So the dialysate rate is 1000 ml per minute. The pre-dilution fluid replacement is 1000 ml per hour. The post-dilution rate is 0. The effluent flow rate is 2100 ml per hour. So what is the fluid removal per hour for this case? So before going into the details about the fluid removal, briefly looking at CRRT, CRRT could be it could be a continuous veno-venous hemofiltration, a veno-venous hemodialysis, or it could be a veno-venous hemodiafiltration. So each of these mechanisms, there will be a different mechanism of solute removal. So in veno-venous hemofiltration, there is a convection mode which helps to remove the solutes by the mechanism called a solvent drag. So basically there will be a semi-permeable membrane, and because of the hydrostatic pressure, there will be a hemofiltration which happens. And because of along with the solvent, solutes will be removed in this veno-venous hemofiltration method. Here, a replacement fluid has to be given. This can be given either pre-dilution, which is before the filter, or post-dilutional replacement fluid, which is after the filter. In case of a CVVHT, that is hemodialysis, here, just like in here, there's a dialysis membrane with the dialysate which is going in. So this is similar to hemodialysis. So here, the method of solute removal will be diffusion, where the solutes go across a concentration gradient across the membrane and solute removal happens. In hemodiafiltration, both these mechanisms are incorporated. So basically there will be a dialysate membrane, dialysate, and there will be hemofiltration happening, which necessitates the application of post or pre-dilutional fluid replacement. So what is a CRRT dose? CRRT dose is defined by the effluent fluid rate. So it is recommended to have a CRRT dose of 20 to 25 ml per kg per hour. This is because higher volumes of more than 40 ml per kg per hour have not shown to have any survival benefit. So a dose of 20 to 25 is recommended. So how do we calculate the net fluid removal for any patient? So effluent flow rate is nothing but it is a sum of the dialysate fluid plus the pre-dilution replacement fluid plus the post-dilution replacement fluid plus the net fluid removal. So if we need to calculate the net fluid removal, just subtract the dilution, the pre-dilution or the post-dilution replacement fluid plus the dialysate from the total effluent flow rate. So what are given in these in this question, it is given that the effluent flow rate is 2100 ml per hour. So that will be equal to the dialysate rate of 1000 plus the pre-dilution replacement rate of 1000 plus the net fluid removed. So when we subtract this from the effluent flow rate, we'll get the net fluid removal, which is 100 ml per hour. So the next question is regarding acid-base balance, which is false. So the use of 0.9% sodium chloride for resuscitation may result in an increased plasma strong ion difference. This is a false statement because the plasma strong ion difference will decrease in hyperchloremic metabolic acidosis based on the Stewart approach. So before going on to the other statements, we'll see the acid-base balance based on the Stewart approach. So the physiological approach is usually a bicarbonate-centric approach, which is based on the Henderson-Hasselbalch equation. So Stewart proposed a physicochemical approach in which there is a quantitative acid-based analysis done. Here, it is not based on bicarbonate because bicarbonate becomes a dependent variable in this method. So there are three independent variables which will clinically mediate the acid-base status in Stewart approach. They are PaCO2, the total weak acid concentration, which is mainly composed of albumin and phosphate, and the strong ion difference. So these are the three independent variables which are going to have an effect on the acid-base status of the patient. So apart from this, the other factors such as your respiration, the kidneys, liver, and the GI tract, all these will have some kind of modifying effect and regulatory effect on the acid-base status. But the primary factors which determine the acid-base status will be strong ion difference, PaCO2, and the ATOT, which is the weak acids. So what is strong ion difference? It is the difference between the strong anions, strong cations, and the strong anions in the plasma. So strong cations would be your sodium, potassium, chloride, lactate. Minus the strong anions, the most important would be chloride. It could also be sulfate and hydroxyl ions. So the difference between these two will give the strong ion difference because the most predominant cation will be sodium and the most predominant anion will be chloride. Sodium minus chloride will give the strong ion difference. So normally this is around 40 just for a simplification of our calculations. So the difference, this strong ion difference that we calculate by just subtracting sodium minus chloride is called as the apparent strong ion difference. And the effective strong ion difference is basically the sum of the bicarbonate level and the ATOT, which is nothing but the albumin and the phosphate level. So normally in normal plasma, this apparent and effective strong ion difference should actually be 0. So if there is a difference between the apparent and the effective strong ion difference, that means that there is some unmeasured anion or some unmeasured anions which are contributing to the acidosis. So this is called as the strong ion gap, and this will correspond to the anion gap method of interpreting the acid-base status. So the anion gap minus the ATOT will give the strong ion gap. So what is the advantage of the strong ion difference method over this anion gap method? Anion gap does not take into account albumin as well as phosphate, and it can lead to a wrong interpretation of metabolic acidosis. However, if the anion gap is corrected for albumin and phosphate, then it is as good as a strong ion difference for interpreting acid-base disorders. So when your strong ion difference is low, it means that it is a metabolic acidosis. If it is due to a high chloride, it is called as hyperchloremic metabolic acidosis. And if it is due to a low sodium, it is called as dilutional acidosis. And if the strong ion difference is high, it is a metabolic alkalosis. And in which, again, if it is because of a high sodium, it is called contractional alkalosis. If it is because of a low chloride, it is metabolic alkalosis. So what is the disadvantage of the strong ion difference approach? So the problem is that this calculation depends upon multiple measurements, each of which is subject to its own laboratory error. So because of this, if all these calculation errors will be cumulative, it will actually lead to wrong values. So it may be very difficult to interpret the acid-base status. So going back to the question, so the use of sodium chloride 0.9% normal saline for resuscitation may result in an increased plasma strong ion difference is false because hyperchloremia will lead to a decrease in the strong ion difference, which will actually lead to metabolic acidosis. So the other three statements coming to renal tubular acidosis. So in renal tubular acidosis, the urine strong ion difference is high while the plasma strong ion difference is low is the correct statement. And in type 2 renal tubular acidosis, there is an increased proximal tubular chloride reabsorption is also correct. So looking at the urine strong ion difference, this is again the difference between the sodium, potassium and the chloride in the urine. This is actually analogous. It is mathematically equivalent to the urine anion gap. So normally what happens whenever there is a metabolic acidosis, it could be because of a high anion gap metabolic acidosis like lactic acidosis. The urinary system will usually react by increasing the excretion of chloride. Thereby, the plasma chloride will decrease. So, the increased excretion of chloride will actually decrease the urinary strong ion difference. So, this indicates that the renal function is normal. And how does it increase the excretion of chloride? By using ammonium ions. So, ammonium chloride will be used as a method to excrete the chloride in order to compensate for the metabolic acidosis and improve the strong ion difference in the plasma. So if there is a concomitant decrease of the strong ion difference in the urine, along with the decrease in the strong ion difference in the plasma, it demonstrates that there is a proper renal response. Otherwise, there is an improper urine acidification, which is what happens in renal tubular acidosis. So in renal tubular acidosis type 1 and type 4, basically that is distal RTA and hyperchloremic renal tubular acidosis, there is a problem with the acidification of the urine. So the distal tubule of the kidney will fail to adequately excrete the hydrogen ions into the urine. So as a result of which, normally under normal conditions, this distal nephron will promote the reabsorption of bicarbonate and ammonium production, which will help to maintain the acid-base status. So, however, because of the in distal RTA, what happens? Because of an impaired excretion of the hydrogen ions, there will be a reduced excretion of ammonium ions. As a result, chloride excretion is also reduced. And as a result of which, the overall strong ion difference in the urine will actually increase. Similarly, in type 4 RTA, where there is a deficiency or resistance to aldosterone, again, there is hyperkalemia and also inability to excrete the H plus ions. Again, similarly, because of inability to form ammonium chloride ions, the chloride excretion is reduced. So there will be an elevated urine strong ion difference in renal tubular acidosis. In proximal, that is type 2 renal tubular acidosis, there is an impaired reabsorption of bicarbonate. So it is diagnosed by a presence of bicarbonate with fractional bicarbonate excretion level of more than 15% when bicarbonate is given. So again here, in proximal RTA can also be explained based on this Stewart approach, where because of the loss of the urinary bicarbonate, it results in a hyperchloremic acidosis. Because the bicarbonate level is low, the chloride level will increase. So reciprocally, there will be a retention of chloride, and as a result, there will be a decrease in the strong ion difference. The final option was acetazolamide. So what does acetazolamide do with respect to strong ion difference? So the option given here is acetazolamide increases the renal excretion ratio of sodium to chloride. So acetazolamide, it is a carbonic anhydrase inhibitor. It increases the excretion of strong cations along with the bicarbonate and causes retention of chloride, and thus it decreases the strong ion difference, and thus it causes a metabolic acidosis. So acetazolamide induced loss of bicarbonate will facilitate the renal reabsorption of chloride. But sodium could still be excreted. As a result, it does increase the ratio between the sodium and chloride excretion in the urine. So the next question is about thromboelastography. So this is a 65-year-old male post CABG and AVR. He has a chest drain output of more than 200 ml per hour. And the labs show a platelet value of 75,000 per microliter and a PTT of 45 and INR of 1.5. What is first indicated in this patient? So a tech figure is given here. So before interpreting this figure, looking at the basics of thromboelastography. So thromboelastography is a viscoelastic assay. Here it assesses the clot kinetics, the clot strength, and the degree of clot lysis. So it is a quantitative as well as a qualitative measurement of the function of all the components of clot formation and lysis, including platelets, clotting factors, fibrinogen, etc. So the mechanism is a pin will be suspended from a torsion wire, which is immersed in a cup of whole blood, and this cup will be continually oscillating, and this will be transmitted to an electromechanical transduction system, and the results will then be displayed in a graph. So looking at the kinetics of the clot based on the values on this graph will give us an idea about the coagulation status of the patient. So what are the different components here? First is the R time, which is otherwise the reaction time, which indicates the time for the onset of the clot formation. So it indicates about the adequacy of the coagulation factors and also the presence of any anticoagulant. Next is the K time and the alpha angle. Both these will depict the clot kinetics. So the K time is nothing but the time for the clot amplitude to reach 2 millimeter from 2 millimeters to 20 millimeters. And the alpha angle is basically, it's a slope. It is a tangential line from the point of the clot to the slope of the developing curve. So both of these will indicate fibrin activation and polymerization. And then we have the maximum amplitude. So this maximal amplitude basically indicates the clot strength, and it reflects the platelet function primarily and also the fibrinogen activity. And finally, we have the L by 30. L by 30 is actually the reduction, the percentage reduction in the area under the TEC curve, which occurs at 30 minutes after the maximal amplitude is reached. So this indicates a fibrinolysis. So if it is increased, it probably means that a hyperfibrinolytic state is present. And using the shape of the TEC curve, it can be used to grossly identify what disorder is present. So how do we interpret the thromboelastogram values? So if the R time is prolonged, it means that there's a problem with the coagulation factors. So the treatment should be a fresh frozen plasma. If the K time and the alpha angle are abnormal, if the K time is prolonged and the alpha angle is less, it means that there's a problem with the fibrinogen. There could be a decreased fibrinogen, so cryoprecipitate has to be given. And if the maximal amplitude is low, that means that mostly it depicts a decrease in platelet count or platelet activity, but it also is influenced by fibrinogen levels. And clot lysis, if there's excess fibrinolysis, it has to be treated with an antifibrinolytic agent. So coming to this question, so in this curve, it is given the value of R is actually 15.6, which is much above the normal value of 4 to 8. The other values like the K time, the maximal amplitude, the L by 30 are more or less normal. So what is first indicated in this patient would be a FFP, because this depicts a decrease in the clotting factors. So going to the next question, in a critically ill patient, which of the following is compatible with a diagnosis of sick euthyroid syndrome or non-thyroidal illness syndrome? So the answer here would be a normal T4 TSH and an increased reverse T3 and low T3 levels. So euthyroid sick syndrome or non-thyroidal illness syndrome, it is usually caused by an acute stress like trauma, surgery, burns, or a myocardial infarction. So what happens here? There is the normal negative feedback regulation in the hypothalamic pituitary thyroid axis is lost. And this can be caused by cytokines, including your IL-1, IL-6, and TNF-alpha, which are all part of the acute phase response. And these will produce a decrease in the thyroid hormone levels. There will be an inactivation of T3 to RT3, which is again has been studied to, in a study it has been found to be an adaptation in a fasting or starvation state to conserve energy. So as we can see here, inactivation of T3 to reverse T3 is seen in this condition, and the TSH will not be elevated even though the T3 levels may be T3 and the T4 levels may be slightly low. So the best option in this condition would be B. So regarding spinal cord injury, which is the correct statement? So anterior spinal cord syndrome is characterized by a lack of pain and temperature sensation, and intact vibration and proprioception below the level of the injury is the right option. And spinal shock is characterized by hypotension, bradycardia, and vasodilatation is wrong because that is neurogenic shock. And the current recommendation to maintain MAP between 65-70 is not exactly accurate because a higher MAP may be maintained to preserve the spinal cord perfusion. And a definite recommendation to administer methylprednisolone within 8 hours of injury is wrong because there is no definite recommendation regarding steroids. So when we look at the spinal cord anatomy, there are three important tracts that we should know. The ascending tract, which is your lateral spinothalamic and the ventral spinothalamic tract, which mediate pain and temperature and light touch. The dorsal column, which mediate deep touch, proprioception, and vibratory sense. And the descending motor tract, which is the corticospinal tract, which is the motor pathway. So the spinal cord syndromes will be characteristic patterns of neurological deficit, depend upon which part of the spinal cord and which tracts are affected. So in anterior cord syndrome, there will be an injury to the motor and sensory pathways in the anterior part of the cord. So this is characterized by paraplegia, a loss of pain and temperature sensation below the level of the lesion. However, because the dorsal column is intact, the proprioception position, that is position sense, the vibration and the deep pressure sense will be preserved. And anterior cord syndrome has the poorest prognosis among the incomplete injuries, and usually it occurs following cord ischemia or severe flexion injuries. Central cord syndrome, here there is a disproportionate greater loss of motor strength in the upper extremities compared to the lower extremities with varying degrees of sensory loss. So here it is caused by a hyperextension injury, especially in a pre-existing cervical canal stenosis. This has a relatively better prognosis. And the Brown-Sequard syndrome, again, this is usually due to a penetrating trauma and hemisection of the cord. Here there will be ipsilateral motor loss and the loss of position sense, and contralateral loss of pain and temperature sensation. That is because the spinothalamic tract will cross over in the spinal cord before reaching the brain. The Asia impairment scale is used to assess the degree of the neurological impairment, and it is also used for a accurate communication regarding the status of the patient. So the level of injury again varies. The bony level is not the same as a neurological level. So bony level is where the vertebral level at which the damage has happened, whereas neurological level is defined as a most caudal segment, which has both normal sensory as well as motor function on both sides of the body. A sensory level is again the most caudal segment where the normal sensory function is present. Motor level is the lowest key muscle, which has a muscle strength of more than 3 out of 6. So neurogenic shock results in a loss of vasomotor tone and sympathetic innervation to the heart. So when there is an injury to the cervical or upper thoracic spinal cord levels, T6 and above, it causes an impairment of the sympathetic pathways. As a result, there is loss of vasomotor tone. So this leads to vasodilatation of the peripheral blood vessels, leading to pooling of blood and hypotension. And because of loss of sympathetic innervation to the heart, it causes bradycardia, or at least there is a decreased tachycardic response to hypovolemia. So treatment would be judicious use of vasopressors after volume placement. So the problem with neurogenic shock is the tachycardic response seen in hemorrhagic shock will be masked. It is always essential to look for other causes of shock even when neurogenic shock is present. And it should not be confused. Neurogenic shock should not be confused with spinal shock. Spinal shock is nothing but the flaccidity and loss of reflexes which occur below the level of the lesion immediately after injury. So this will eventually progress to spasticity. So spinal shock is different from neurogenic shock. So whenever there is a spinal cord injury, there is always a chances of secondary injury which occur because of hypoperfusion, which could be because of hypotension. So the current recommendations is that hypotension should be avoided in all patients with spinal cord injury and also to maintain a MAP between 85 to 90 mm of mercury for at least 7 days after the injury. However, this is only based on class 3 data, and the decision to maintain a higher mean arterial pressure has to be weighed against the risk of use of vasopressors, need for invasive monitoring, and also need for using higher critical care resources. So it has to be based on the patient's condition. So there is no recommendation for steroids in spinal cord injury, considering the much higher adverse effects associated with steroid use. So the final question is in relation to paracetamol poisoning, the true statement is, so the first statement, N-acetyl parabenzoquinolamine is produced by glucuronidation of paracetamol in the liver is definitely wrong. And the toxicity nomogram is not reliable in cases of staggered overdose. And hypersensitivity is not a contraindication to N-acetylcysteine. And plasma levels above 100 milligram per liter at 4 hours and 15 milligram per liter at 15 hours would ingest after the ingestion would warrant a treatment. So when we look at the metabolism of acetaminophen, in normal conditions, 85 to 90% would be undergoing conjugation with glucuronide and sulfate, and only 5% will undergo oxidation by cytochrome oxidase, and that will be converted into NAPK, which is a toxic metabolite. And usually this is taken up by, conjugated by glutathione and then converted into non-toxic metabolites, which are then excreted in the urine. So in massive overdose, this mechanism of glucuronide conjugation will get saturated, so there will be a high cytochrome metabolism producing very high levels of NAPK, and the glutathione stores will also get depleted, which leads to hepatocellular necrosis and all the multi-organ dysfunction which is associated with paracetamol overdose. So whenever there is a patient presenting with acute overdose, the value of the serum level of acetaminophen should be measured. So it is ideally measured at 4 hours post ingestion or even later if the patient presents later. And the value of the plasma concentration, it is plotted against the time. And based on this nomogram, if the level is above the lower line, that means that there is a high possibility of risk of hepatotoxicity and N-acetylcysteine is immediately started. So this will correspond to a value of 100 milligram per liter at 4 hours and 15 milligram per liter at 15 hours. That will correspond to this line. So that is the correct statement. And regarding the staggered overdose, obviously this Rumack-Matthew nomogram was actually designed only for an acute and high dose ingestions, and it is not meant for staggered overdoses. So it is not at all reliable. So in those conditions, whenever there is a suspicion, it is always better to start. Also, we can look at repeat levels of the paracetamol or the hepatic transaminase level. If they're elevated above the baseline, it is better to treat using N-acetylcysteine. And even though hypersensitive reactions may happen, the benefit much outweighs the risk associated with hypersensitivity. So it is not a contraindication to use N-acetylcysteine in these patients. So that comes to the end of this debrief video.
Discussion group in the WhatsApp group. If there are no further questions, then we can end the session. Any questions? Ma'am, we can end the session if there are no questions, ma'am.
Yeah, thank you then.
Thank you. Thank you, everyone. All the best.